Our next speaker, Dr. Jane Delgado, is the President and Chief Executive Officer of the National Alliance for Hispanic Health. Dr. Delgado is a highly respected and well-known activist, writer, thought leader, and commentator who has dedicated her career to transforming health. Just this week, the Association of American Medical Colleges honored Dr. Delgado as one of 10 Hispanic pioneers in medicine. A clinical psychologist, Dr. Delgado is the author of more than 10 books, including 2020's Understanding Depression and Enjoying Life. She is going to address how a lack of inclusion, systemic racism, poor access to health care, and mental health coverage affects Latino health and methods for moving forward. Dr. Delgado? Is Dr. Delgado able to join us?
Hello? Hello?
Yes, Dr. Delgado.
Okay, I'm sorry. I thought I was talking to myself.
That's okay. We can hear you now.
Okay, so thank you, Lisa, and thank you, Sherry. You know, this is a very important time for all of us, and I want to thank everyone who's here listening to this presentation, because this is a time when we can move from what the past was, which was ignore or false assumption, to inclusion. And this is important for all of us. And I think that part of what you need to see is who we are, the National Alliance for Hispanic Health. And you need to understand that we're a nonpartisan health organization for research, service, and advocacy throughout the Americas. So we actually fund programs in Latin America. We also do not accept funding from tobacco or alcohol or sugar-sweetened beverages. And this is makes us really advocate best health for all. Now, you see the name Hispanic in our name? Well, about 6 years ago, we changed our mission from improving the health and well-being of Hispanics to best health for all, because we realized in order to help everyone, we had that by helping everyone, we also helped Hispanics. And what you need to know is that a person's values, when they speak to you, are very important. And these are our organizational values throughout the alliance that I lead. I also want to know that we have a research arm at USC, and we also focus the alliance on programs on diabetes, cancer, and are part of NIH's All of Us activity. With that, you need to know that what we value are three things: people, science, and culture. Those are three things that are the underpinning of everything that we do at the Alliance. And when we talk about how come we're having such a problem with Hispanics in healthcare, frankly, this is not a new surprise for most people. The reality is that we are the group that is most likely to be uninsured. And the reason that we are uninsured, and we are the purple layer, you can see for all groups not insured by age, race, and ethnicity. Although the ACA did a lot for us, a major determinant of whether or not we're insured is what state we live in. States like Texas and Florida, where there are a lot of Hispanics, where the total number of Hispanics in Texas and Florida combined equal all the Hispanics in California. Texas and Florida did not do Medicaid expansion. And as a result, that really drives down the number of Hispanics who actually have insured. And some people say, well, you know, I'm not too sure about these data and what they mean. And I said, well, you know, even if you look at it by gender, what you still see is that Hispanics, which are the purple line, are still underinsured. We have no insurance, and it's a problem throughout the ages for men on top and for women on the bottom. And then, of course, people like to talk about, well, Hispanics are so diverse. Maybe it has to do with, you know, the country of origin. When we looked at those data from the Census Bureau, we found a very important pattern, that the group most likely not to have health insurance are people ages 18 to 64, across whether you were Mexican, Puerto Rican, Cuban, Central American, South American, or other Hispanic. This was the group that is least likely to have health insurance, and yet this is a group where we can have a major impact on health issues. Now, one of the things which is most amazing to me is that when people talk about health, they try to think of it from their perspective. But I like this picture with all the windows because, in fact, the window you look out of colors what you see. And one of the things that most people don't realize is the size of the Hispanic population. So there are 59 million, it's 0.6, you can say 60 million, but, I don't want to exaggerate, so I'll just stick to 59.6. So there we go. And what does that tell you? People say, well, Hispanics are so diverse and they're of, multiple races, but, all of these groups are diverse. There's no group which is all the same. If you talk to non-Hispanic whites, they're a very diverse group also. Yet for the purposes of our current systems, we do aggregate them. So I need to emphasize that our current systems are part of what we're using, but that that system is changing because as we get better data, we can get more specificity about the individual that is sitting in front of you. And that is key because personalized medicine will make many of the current debates about if you're Hispanic or Latinx or if you focus on the country of origin, really looking at who that person is. And also the labels that we use are constantly changing because how people see themselves is constantly changing. And a good example of this is that for a long time people used the term people of color. And this was an op-ed piece that recently appeared in the Washington Post by a former congresswoman. And what it basically says is, I don't want to be called a woman of color. I am a black woman. We are black women. And the reason is because each community has their own heritage, has their own experiences. And those experiences have an impact on their health. And we know that because that's what epigenetics is about, how the things which are around us change the way genes express themselves. When it comes to the Hispanic community, in fact, one of the problems that I see is that most people have very little knowledge of our history. The culture sort of forgets that arrival and acquisition is part of the Hispanic experience. And most people in the Northeast, I'm sorry to say, are not aware of the U.S.-Mexico War or the Treaty of Guadalupe Hidalgo in 1848 and what that meant. Most people do not know that Puerto Rico was annexed in 1898 as part of the Spanish-American War. That history, or even that Florida was first founded by the Spanish, a lot of people don't know our history. So our history is very diverse, which in a way is different than the African-American community that can trace themselves to a common event that brought them here, which was the horrific slavery. So I think part of it is understanding how people became part of the U.S., what that history means, and how that impacts their lives today. The next thing that I always say is when you're talking about what's going on in institutions, you really have to talk about how accurate is it what we know. And frankly, it's not very accurate. For a long time, what we used to do is use something in health called reference man. And this reference man was used for looking at the estimation of radiation doses, and it was first used in 75. In 2010, they were still looking for a modern reference man, but that was used for all sorts of things besides radiation, cancer, the effects of toxins, and all sorts of things like that. So really, those data weren't very good. But needless to say, even with bad data, we always made assumptions. So when these data came out that Hispanics lived longer than non-Hispanic whites, it was people doing cartwheels trying to say that this could not be possible because of all the vulnerabilities that people know are part of the Hispanic experience. But somehow we lived longer. And it was contrary to a minority model or myth about minorities that we actually lived longer. Hispanics became even more controversial in how the health system would treat us when our rates of heart disease mortality also showed that we did better than non-Hispanic whites. And one of the problems I always see is when people look at what the goal should be for health, they say, well, let's do what let's go to the non-Hispanic white standard. And my response is no. In rates of heart disease mortality, let's go to the Hispanic standard. Everyone should be better than the best, and in this case, we're the best. It's a similar situation when it comes to what we know about population pregnancy-related mortality ratios. Across all ages except 35 to 39, Hispanics actually did not better than non-Hispanic whites. So what does this mean? Well, it means that, as Hispanics, we live long and suffer. And the problem with that is that our conditions, depression, diabetes, arthritis, and liver disease, are things that are not looked at as carefully as they should. As a result of that, what you have is artificial intelligence and decision-making tools which create a system that does not include information about Hispanics, and that damages the outcome for people who go in there, but also is really not a tool for the clinician. I want to add that it's not just having good data, it's also the analysis. You have to also go beyond the numbers. So when NIH first announced that, from 2009 to 2016, they now had many more data on non-Hispanics. It went from 4% to 19%. People were thrilled. But when they really looked behind the data and they said, what is going on here, the data increase was for Asian. For African Americans, it only went from 0.57 to 3. And for Hispanics, it went from 0.06 to 0.54. So you really had to look at more than just the big data, but drill down. Finally, what happens when people do not look at all the data? A good example is the American Cancer Society guidelines for the prevention and early detection of cervical cancer. These just came out July 30th, and they have their guidelines. Then at the very end, they talk about the limitations for these guidelines. And who are these guidelines limited for? Black, Hispanic, and lower SES status women. Why? Because those populations are not optimally represented in randomized controlled trials. Let me say, not optimally is an understatement. Those communities are not represented adequately. So where does that leave us? Well, this leaves us that we have a challenge. If we're going to move from the idea of going from ignore to inclusion, we really have to look at many things. And these things are some things that are critical to change. And it's not just about having a program. It's about having leadership, board, staff, and constituents that are inclusive, about having accurate data, about having meaningful analysis, and a capacity that goes beyond the numbers, like what I showed with the cancer guidelines. And to understand that personalized and targeted is the way to go. And I'm sure some of you are thinking, well, you know, she's a psychologist. Isn't she going to talk about mental health? Well, the bottom line is health is mental wellness, and you can't have health without including mental health. But mental health is something that you can talk to people when there's a trusting situation, when the trust, which is earned over time and experiences. You know, when people come to me and says, what can I do to gain trust? And I said, well, you have to spend time on it. And they go, oh, well, that's not what they want to do. You have to, trust is gained over time, not one moment, but over experiences. The role of community health workers is key in mental wellness. They are a big way to get people into mental health services. Culture and language need to be celebrated, not just acknowledged. And we have to go beyond translation. In mental health, language is more than just what you can ask. You have to be able to listen to the people. And with that, I want to say my thank you to everyone who is out there for all you do to achieve the best health for all. That's a real picture of our headquarters, and yes, that's a real rainbow. It's not fake. So that's about all I can say, and I wish everyone all the luck and all the work that you do.